Oh my God, PECS is amazing. We really should have called it PECS. No, it's PEACS.
Okay.
I wish it was PECS though. And if we can leave that in there, that'll be great.
Hello and welcome back to this week's episode of the Science or Fiction podcast, the podcast that interviews researchers to separate the science from the fiction in news headlines. I'm Mariam Shah and I'm a clinical psychology trainee at King's College London.
And I'm Dr. Catherine Bates. I'm a youth development researcher at King's College London.
And this is the Science or Fiction podcast. So chronic pain is experienced by around 34% of adults in the UK and 1 in 9 young people worldwide. Pain can be defined as a negative sensory experience and emotional experience too. It can impact all areas of life. And with many individuals experiencing mental health difficulties alongside this. For those with chronic pain, this experience persists for 3 months or more. Not everyone experiences chronic pain in the same way, and inequalities in healthcare can make it even more difficult for some individuals to get the support that they need. Today, we're talking to Misha Gardner, the project manager of the PEACS programme, co-designed with Black people to support them in living with chronic pain. We will find out more about chronic pain and how healthcare can be designed with and for patients. So to begin with, could you just tell us a little bit about what you do?
Oh yeah, thank you. As you said, I'm the project manager for the PEACS programme currently, and I work as part of the Mind and Body programme at King's Health Partners. And the whole ethos of Mind and Body is to support integrated mental and physical healthcare. So it's to support people to think of healthcare in a more holistic way, bringing together physical health and mental health, and not treating the person as a condition, but more thinking about them as an individual, a whole person. And so we support kind of whole person-centered approaches. I look after the PEACS programme, as mentioned. So I think a project manager is a sort of occupation that people, they kind of hear often, but they don't often know what we do. And so I'm going to struggle now to tell you what I do. My job is very varied, but essentially, as a project manager, you're expected to deliver a project based on the aims and objectives set out originally in the beginning. So essentially, my role is to have complete oversight of the project. So that's looking after all of the different work streams across the projects. That could be the evaluation. That in this situation anyway, it's the evaluation, it's the kind of co-design element that we had, and I know we're going to talk about some of that today. It is comms and engagement. It's looking after our kind of patient and public involvement. It is actual implementation, so actual delivery of the pathway across primary care. It's also doing other sort of mundane tasks, and I say that, like not lightly, because all of these things have been so crucial for our project. But things like recruitment, so thinking about recruiting new staff members, documentation, like things like developing project plans, facilitating learning reviews, thinking about staff well-being as well is something that people don't often think about. But when you are a project manager, you're not only looking after a project, you're looking after the people that are working on and delivering that project. And so a large part of my responsibility, I would say, was to think about the delivery team. And in our delivery team, there were GPs, clinical psychologists, assistant psychologists. We had sort of patient engagement leads, thinking about everyone, because I think this project and the population that we were supporting have a lot of complexities. And dealing with that and engaging with that day to day is not easy. It often can be very challenging. Not specifically the people are challenging. I think sometimes the lack of understanding and the issues that are presented can be quite difficult. And so just thinking about them as well and keeping their kind of well-being at the forefront of my mind. So being a project manager is a multifaceted job. It's for the most part, it can feel like it's not very rewarding, but I think with the PEACS programme, I was very, very lucky to be surrounded by an incredible team. a very thoughtful team, a very kind team, a very compassionate team, an extremely diverse team. And I don't just mean diversity in ethnicity, I mean diversity in their expertise. Everyone came from different backgrounds, came with different knowledge, different skills. And so we learned a lot from each other. Patient service users, they were incredible, absolutely incredible. The fact they trusted us in the first place with this project. It was completely new. No one had ever, done anything in the patch before like this. And so they trusted us by engaging with us. And so they made all of this possible, and they're kind of the reason why I'm here today. So that's my role.
That's brilliant. Thank you. I wonder if before we get more into the detail, can we just say what does PEACS stand for? And then you've mentioned your service users and the really important role that they had. So who was it aimed at?
Yeah. So PEACS stand for pain, equality of care and support in the community. So that's PEACS. And the sort of target population, so based on sort of local prevalence data, a huge priority of the programme was to support people from Black communities. In order to tackle those health inequalities anyway, we had to do some proactive outreach, targeted outreach to people from Black communities.
Yeah, thank you so much for giving such a helpful overview of your role as well, and the different sort of members of the team, as well as the sort of people that were being served by the project. And it really just gives like such a brilliant insight into how much thought and different perspectives and consideration go into making a project like this sort of function and work. You touched on sort of the disproportionate representation in people in Black communities of experiencing chronic pain. And I was wondering, in your experience, why sort of do these inequalities in chronic pain come up? Is it related to who is experiencing chronic pain more often? Or is there something, different about sort of inequalities experienced in healthcare and access to services and who receives treatment that sort of inform why that's the case?
Yeah, and I think it's all of those things that you just mentioned. So on a basic level, there are kind of socioeconomic factors that kind of contribute and help persist health inequalities. So we think about people's sort of educational background, people's employment status, income, where they live in the country. This can sometimes disproportionately affect their access to good quality healthcare, their experiences as well, because we all know, although everyone's working in a role, everyone, everyone has a title, let's say, you can have a doctor, you can have, whatever the title may be. We all are individuals with our own individual experiences, and unfortunately, we all have our own individual views and perspectives of the world, and these are informed by things in the media and just day to day, going about our day. And so unfortunately, these things can be brought into the workplace, and that's why there was a big movement towards unconscious biases and things like that, because I think there is unconscious bias training, there is sort of the perception that, these are professionals, they should know how to interact with individuals, and that is true for the most part, but they also are individuals as well, and people underneath these titles. And so they will bring their own experiences into the workplace, and that can have an impact, or it can sort of perpetuate these health inequalities. I think, just going off of what I was just saying as well, I think we know historically that, and I'm saying this in relation to my project, Black bodies have been used to advance Western medicine historically. And that can cause a lot of trauma, and that can lead to mistrust in healthcare services. So I think there's a hesitation sometimes from certain groups to share information. So, for example, we know that ethnicity data across primary care is really bad. And I think sometimes that's because people, from my experience, I often say in a job application, I prefer not to say, because I'm worried that my ethnic background will stop me from getting to the interview stage. And that's a very personal thing that I've shared. I'm happy to share that. And I think it's the same in sort of people's healthcare experiences. They sometimes feel, or they might feel, should I say, their ethnicity presents as a barrier to getting good quality care. And the data sort of supports this as well. We know that there are healthcare inequalities, ethnic health inequalities for people from marginalized, Black and minoritized ethnic groups. And then I think as well in my own work, so with the PEACS program, we saw in some sort of local secondary data, we saw inequalities in terms of access. So people's choices to refer people onto or individuals into sort of that tertiary care, more specialized chronic pain service, is sometimes informed by their own prejudices, their own sort of discrimination. So even though we see in the data that Black Caribbean women are most likely to live with chronic pain than sort of white women, we saw that, and double the rates, we saw that the reverse was true in terms of those who were referred into more specialist services. So it was actually, white people that were getting more referrals into those more specialist tertiary care services than it was Black people. And so there is an inequality around patients' access to, again, just that good quality care.
And it's already becoming really clear how some of noticing these different processes, whether they're like socioeconomic or sort of institutional, are sort of forming the basis for how this project has begun to develop.
Yeah.
One of the things that you mentioned was how information from sort of the media or narratives in society can inform our perspective on how people with chronic pain are viewed. One thing that's like often referenced is how it impacts on people's ability to work, but also sort of the stigma and emotional experience alongside of this. So, for example, one article I was reading in the BBC recently had the title, "I hid my pain from loved ones for 25 years." And I was really interested to sort of know from your experience of working with people with chronic pain, what might lead to a person feeling that they might need to hide their pain in that sort of way.
That's a good question. Thank you. So there's two sides of this argument. Some of it is not intentional and some of it is. In terms of the unintentional aspect, chronic pain is an invisible condition for the most part. Most of the people that I saw and encountered with these past 2 years are not screaming out in pain 24/7. They're not going to do that in their job. They're not going to do that in public. They're just not. They're just going to live with it, unfortunately, bear the pain. Some of them are in excruciating pain and you would never know. And so I think that invisibility causes an emotional burden on people, because I think in society, unless you see someone physically in trouble or in distress or hurting, then I think sometimes people can sort of lack the compassion for people. And so I think what we saw through the co-design element is that there is an emotional burden for people to keep having to describe what they're going through on a day-to-day basis, because as I said, most people look okay. And I was just doing some filming on Friday actually with one of our groups, and a lot of them, I mean, they look so good. Trying to convince someone what you're going through day to day and having to describe that, I think is an emotional tax on an individual. And I also think there's kind of a physical burden as well. So there's a physical tax attached with it. I think a lot of these people, if we're thinking about, like Black Caribbean women, naturally we are caregivers. And so they have families, they have dependents, they have children, they might, have husbands, whatever, partners that they're living with. They are kind of responsible for a lot of the sort of caregiving roles and responsibilities in their sort of immediate circles. And so I think there is a worry about putting undue stress onto the people around them, and also not feeling like they want to be a burden to other people. I think what is the most common narrative around Black women is that we're strong. And I think that label has been so damaging. Speaking as a Black woman, yes, we're strong, but sometimes it doesn't then give us the opportunity to be weak when we need to and ask for help when we need to. And so it kind of perpetuates what they're going through again. So it's kind of like a vicious cycle. And then also feeling like people don't want to hear it. So I think if you think about any chronic condition, I think there is a worry that you come across as like you're moaning or you're complaining, or, like you're being miserable because you're talking about it. And again, they have to talk about it because no one can see it. And I think this is made worse by their interactions with people in healthcare. There's this helpless dynamic, I think, in healthcare between the healthcare professional and the patient that has been going on for so long, hence why this project was so needed, where patients can often feel very helpless. Healthcare professionals can feel very helpless, not knowing what to do or how to support them. The medication is not working, physiotherapy is not working. All these avenues that they've explored have actually not been working, but the patient is obviously still coming to them as a professional, and then just be like, what do you want us to do? Like, we've done everything that we can. And so I think that they often feel burdened out by that. They feel really deflated by that. But I don't think it's just the people that feel that way. The patient, it's also the GPs. And so there's this really unhealthy cycle sometimes that can happen in supporting people with chronic multiple long-term conditions. I think there's also things like an element of shame and disappointment. So if you look at our impact report, which we just published, one of the people in the impact report, the case study that we spoke to, one of the people that engaged in PEACS, said that they felt their body was letting them down. And this can be really difficult. Specifically, we saw a lot of people who were in full-time work, who had very active lifestyles, were traveling. This person was riding bikes all the time. And they had a lifestyle that is different to the one that they're living now. And I do think that a lot of the changes that have happened in their life have been caused by their chronic pain. They haven't wanted to give up, but they have been forced to give up. And I think there is just a sadness. I think there is a disappointment in what's happening to them. There might be feelings of shame as well that sort of cloud that as well, and makes people not want to share what they're experiencing. And then I think finally, just a lack of understanding, a lack of support, and just going back to my first point. I remember speaking to one of our people that are involved in the project, and them saying that they'd often go on the bus and no one would offer them a seat because, again, they look very well. And this person that I'm thinking of, it's incredible, I'll say it, but she looks so good, and people wouldn't offer her a seat, but she was in so much pain, like from head to toe, just in pain. Like, you can't imagine what that's like. But because she wasn't, she wasn't pregnant, or she didn't have a walking stick, or people weren't offering her a seat. And so I think there's just a lack of public understanding as well about chronic pain. I'll be honest, before I worked on this project, I didn't know a lot about it. I know much more now, thankfully, but I didn't before. And so I think there is, going back to that sort of burden element, I think there is sort of an unfair responsibility on people that they may feel to educate others about chronic pain. And again, it's another emotional burden. Why should this person have to go on the bus and say, please? And then can you imagine getting into a dialogue with someone about needing a seat? And that kind of can stop people from sharing and holding back from speaking about what they're going through.
Yeah. You've picked out so many incredible themes there. It could be a whole report in itself, I think, of the experience and the narratives of being a person with chronic pain. That idea of sort of this intersectional identity as well, sort of gender, ethnicity, but also having this hidden condition and how people interact with that and how it can sort of reinforce some of the difficult cycles. It is really so important.
I was just going to add, just to say, thank you so much for sharing the details of those experiences, because like you said, people just don't have a good enough understanding of chronic pain and how it's experienced, who it's experienced, why, who it's experienced by, and why. And I think that's so important, because often when you see it in the media, it's just like, oh, people with chronic pain take up this many percentage of GP appointments, and it's like this burden on the NHS. And it's like way more complex than that, like what people are actually going through and how they're struggling.
Yeah, it's so complex. And those narratives seem to be always be in favor of the healthcare system, don't they? And they just forget people, that these are individuals having an experience in the world. And I like to think that most people come into healthcare because they want to help, people and make things better. But somehow along the way, there's certain groups, certain patients that just get lost in the system. And I think sometimes, like with these overarching structures, we think about the media, we think about, like government, all these education, healthcare, even systems. I think it always comes back to resource and money. And we've lost our way a little bit. I definitely feel like we've lost our way. And I think that one of the beautiful things that came out of PEACS was the co-design and turning some of these top-down, like higher structure perspectives on its head, to actually think from the ground up and build something that is actually going to work for people. And if I was Prime Minister tomorrow, we'd all be doing, co-design. That'll be one of my priorities. Anyway, by the way, I'd never want to be the Prime Minister, just to clarify. But, I think co-design and what we had in this project helped us sort of quash some of those unhelpful narratives that are out there.
Can you tell us a bit more about how you approach the co-design, like how to kind of give an example of how that can work in healthcare?
Yeah, so we were very fortunate. We worked with a co-design sort of expert. So they're a Black-led sort of consultancy agency called Kamuzi at the time. And they were kind of experts on this. So they were experts in doing sort of co-design, co-productive work with different groups, professionals or people with lived experience, and then being able to map out kind of a more suitable offer. And the fact that they were, as I mentioned, that we were supporting people from Black communities, the fact that they were Black helped a lot. And again, going back to what I was saying earlier, it helped to develop that rapport and that trust that we needed from certain groups. I think that was really helpful. And it also brought a level of understanding, just like being Black and understanding what it's like to be discriminated against or be prejudiced against or face inequalities, themselves. I think that was a helpful advantage that maybe we haven't maybe thought about enough. And so they were incredible. So they ultimately led the co-design work, and we worked with them and also a local sort of primary care network, so PCN in Stockwell, to identify patients to kind of interview about their experiences in healthcare. So essentially, we spoke to patients and their carers and some clinicians working in chronic pain to kind of identify some of the challenges and issues, current gaps in healthcare, and to map out some of these to be able to develop a more holistic offer. Again, our target audience was informed by local kind of prevalence data as well and national data. So just to say that this, just to reinforce that idea that this project was encouraged by what we were seeing through research and data. They done these in-depth interviews with people, so with patients and their carers and clinicians. And people were the patients were sharing a lot of helpful insights that we never would have known without the co-design. So again, I just genuinely believe a lot of the stuff that we did wouldn't have been possible without the co-design work. So there were things, there were some of the common things were that they don't feel believed by their healthcare clinician when they're seeing them. They're having to repeat their stories. They're bouncing around from one institution to the next, again, physio, or back to their GPs, back to this, rehab center, And they felt like there was carrying the load of their experiences. So every time they'd visit a healthcare professional, they'd have to repeat their story. And again, it just goes back to carrying an unnecessary kind of burden. There was some of the clinicians, I think, would say that there was a demonstration that there was a lack of understanding, knowledge about chronic pain, but not really about the biomedical side, because obviously they're clinicians, they know that. I think it was more about how to support these patients and what some of the other offers were. So there was an issue around education. There was an issue around education for the clinicians, but also the patients. I think sometimes, and it was interesting, some people felt that even though they know what they're going through, I think sometimes it was hard to put into words. And again, it's like having to sell themselves. Again, that sort of that burden, that tax that it causes on them. And so there was an educational element for the patient as well, to be able to speak about their chronic pain and what they're going through in a way that people could understand, and empowering them to do that. So not just to their clinicians, but also their family members, to other people, people in other relationships. There was a self sort of management element. Sorry, I've just gone straight into the themes of what we found as co-design, but I think it's okay. So there was an educational piece and improvement education. There was a issue around self-management. So for some of these, as I mentioned earlier, the specialist services, or just waiting for physio, there's long waiting lists, and they were sitting on, like we all are in some capacity, sitting on waiting lists with no support. But I think some of us can do that because we're not day-to-day experiencing a chronic condition, so we can kind of manage it. People who have chronic conditions can't manage that on a day-to-day without support. And so there was things about supporting them whilst they are waiting, but also supporting them to be able to self-manage their condition in a more kind of autonomous, independent way, and be able to seek the support from community groups. There are fantastic community services initiatives in Lambeth, like incredible, and supporting them to sort of navigate that system a bit more and know who to turn to, know what's out there. Because again, like some of the clinicians, just knowledge of who's out there and who can help and what they can offer. And I think supporting patients to be able to self-manage and navigate that system as well in their leisure was part of our kind of ethos. And then the third kind of theme that we discovered through the co-design, so this is just through talking to people and based on what we found. So I think we had over 60 raw findings from people that community sort of found. And this is just based on sort of qualitative data. So just what they said. They grouped these findings into these three themes that I'm talking through now. The last one was the importance of coordinated care. And it just going back to that, being bounced around from one person to the next. They'll go and see a chronic pain specialist, and they'll have a scan, they'll go over to physio, and they'll go to this place and that, but just be bouncing around. And I think sometimes culturally, depending on who you are, you might be better at navigating the healthcare system than others. Some people are more aware of their rights as well, and can use that privilege to their advantage, And I also think, just thinking about the target groups, there is sometimes a language barrier as well, and that making it more difficult, it presenting, like a challenge to being able to advocate for yourself. And so we found that people struggled sometimes, again, going back to that access, which is one of the health inequalities sort of strands. People were struggling to get good quality treatment and access to those more appropriate services, I would say, that more so meet their needs. So it wasn't, I think a lot of the services that we have in the system at the moment are sort of governed from that top-down perspective that I was talking about earlier. They haven't considered the needs of the population, the diversity of needs across the population. And so it wasn't just about having good quality services. It's also about those that are culturally appropriate and culturally relevant, which is what we try to do through the PEACS project. Thinking about people's culture, their backgrounds, race, religion, experiences. These all inform how people will engage with healthcare services. And so we encompass all of that context into the project by speaking to these diverse groups. So we were speaking to mainly Black women. We had, like Black men involved, of course, like with chronic pain. But we wanted to take what they said essentially map it onto a pathway. So take all of their needs, map it onto a pathway, with the intention of increasing and encouraging more engagement. And back to that sort of coordinated care piece. So I've gone all over the place here, but essentially we developed a sort of a 7-stage kind of pathway. So people were supported from one end to the other. So they were identified through a chronic pain search that we co-developed through the program, and they were supported through each stage. We had incredible link workers. We had fantastic community connector, assistant psychologist, patient engagement lead that were actively, we had like an army of people that were actively supporting them through the pathway and holding them. Essentially, it's that holding piece as well. And I think that sometimes can be left off, and it's not, I don't think that bit is a fault of healthcare, essentially, because essentially resources are always a problem, and they're a common complaint, resource and capacity. And I think people don't always have the time and the resource to support that kind of holding aspect. But we did have that within this project, thankfully. And so we were able to sort of support their navigation from one stage to the next, from the search all the way to sort of the community support and signposting and referrals. So yeah, that was kind of the co-design, and you know, we went through this whole process that again was led by Kamuzi. It was very iterative. There was lots of testing that happened of the pathway, lots of sort of blue sky thinking and mapping of ideas, what this could look like, you know, like what do we want based on what the patients have said. Oh, they said, you know, they want more representation, you know, like in their healthcare providers, thinking about that when we're recruiting GPs, you know, like making sure we have that diversity in our staff group. Then 10 minutes is not enough time for them, they were saying, you know, in the co-design. Oh, what can we do about that? Okay, let's have, you know, an incentive. Let's have 30-minute assessments. So they really have the time to explore the different challenges that they were experiencing, explore the sort of their chronic pain, and also how we could support them. So it really had a personalized care element to it as well. The self-management, as I said, we developed a toolkit which was there to support them through their journey, but also use outside of the pathway as kind of a diary where they could record their goals, they could record notes after the intervention workshops, and kind of use that. It had sort of key concepts of the 6 pillars of lifestyle medicine framework that we use, which is a clinically evidence-based framework that we use in the pathway, and they could learn more, you know, about, for example, the relationship between nutrition and chronic pain, the relationship between movement and chronic pain, these kinds of things, and, you know, do some of the work outside of the intervention as well and support that self-management. So yeah, go co-design.
Yeah. Yeah, it sounds absolutely vital in just developing things that work for people. It seems like a common theme that comes up is that, like, we don't exist outside of our experiences, or like we don't exist as like, or even like a medical condition. It doesn't just exist as that condition that you can just like give a pill and it will just like something will happen. Like we're completely embedded in all of these experiences, like our identities, all of that kind of stuff. So in order to actually provide people with support and to treat it, you have to approach it knowing that as well, right?
Yeah.
And I read in the report as well, like you mentioned resources and finances and stuff, but in the report it was kind of evaluated as being cost effective. So it seems like these things can work. Like if you put the time into it and frame it in the right way, it can be effective.
Yeah. You know, we want to share that learning with people that we're always afforded the time. And again, it's not about being harsh on people, because we do work in a very pressurized system, but it is about maybe thinking about how you can use the means that you do have to be able to create something that is more suitable, more holistic, more effective, more efficient. You know, all these things will come out if people just sort of take the time to and to think a bit differently about how they work, use a bit of creativity. So I think I left a few points in the report around, you know, using existing resources. You know, like how are you collecting feedback from patients at the moment? Even if you've got a survey, my GP sends me a feedback form, you know, like after every visit. Can you use some of the responses in that to find out what some of the issues are and then build upon that? do you have a expert group? You know, the PCN that we worked with did, you know, like, and so using these forums, using these tools, these resources that you already have, to, you know, like as a kind of quality improvement piece, I think, for want of a better word, to be able to sort of adapt to and meet the needs of your population, and try something a bit different. If you're finding it's not working at the moment, there's probably a reason for that. Maybe just, you know, thinking about a way that, yeah, you can do something a bit differently.
I would, really encourage anyone that's interested in finding out a bit more to have a bit of a read of the most recent report. It's titled Pain, Equality of Care and Support in the Community Impact Report. And it's just also like very visually appealing and very accessible, which I really liked from it. I guess it also within the report, you mentioned taking this biopsychosocial approach to chronic pain. And I was wondering, how would you explain that? What does it mean, and how does it work in practice?
Biopsychosocial, I think it goes back to what we were just talking about. So I think it's just about encompassing sort of all the parts of the lived experiences of individuals, essentially. With the biopsychosocial approach, it takes into account all of their lived parts. So people's immediate relationships, these people's day-to-day experiences, their culture, their religion, their faith, their sort of ethnicity, background, all these things, just taking into account sort of all of these parts of it that make up the individual, and supporting kind of their holistic needs. And I think in addition to that, it's also about considering the mind and body and the relationship between the mind and body and how they are so connected. There's lots of good literature out there, lots of good research, lots of good data, books that talk about this in detail. And it's for chronic pain. Some people would speak about an actual incident or a physical tragedy that would happen. So, for example, people had a car crash, for example, or they fell, you know, and since then they'd experienced chronic pain. But I remember so vividly, I'd speak to some people and I would say to them, how long have you lived with chronic pain? And some people would say, well, all my life. The national sort of data around this recognises that chronic pain is a biopsychosocial condition, and is best supported in that way. There is no one way to get chronic pain. It's not always because something's happened to you. Someone says they've experienced chronic pain in their lives, that, you know, like sparked my interest, and I was like, wow, like tell me more about, you know, your background and what was happening for you. And then you'll hear things that, you know, for most people would sound like trauma. Lots of the chronic pain sort of co-occurs with depression, anxiety and things like that. And so I think it's about just recognizing the relationship and the interconnectedness of the mind and body is a biopsychosocial approach, and the interaction between mental and physical health as well. And so, yeah, just thinking about the whole person again, thinking about their holistic needs, is what biopsychosocial approaches mean, and not treating it as purely a physical health kind of condition.
I think what's really clear from what you've shared is such a sort of person-centered focus,
yes,
in all of the work, and also just your own sort of like passion and advocacy for this population is really nice to hear about. Before we sort of finish up, I was wondering if you have any recommendations for our listeners if they want to find out more about the topics that we've discussed today.
So Body Keeps Us Secure is a book that I would suggest people read. 100%. There's also a book called The Pain-Free Mindset, and also someone that I love personally is someone called Gabor Mate. He talks a lot about trauma and the manifestation of trauma in people's bodies, so autoimmune conditions and things like that. I think definitely check him out. I rate him a lot. If you're into that kind of holistic mind-body relationship, I would definitely look more into that. And then, of course, the King's Health Partners website, but mainly, you know, the PEACS webpage in that. We've got our impact report on there. We've got an evaluation report on there as well, where we list sort of all the main, the incredible findings, the outcomes from this project, where, you know, after 2 years of delivery, we had so many positive things that came out of it around people's sort of experiences. Some people said that we, like saved their lives, dare I say. But we saw, reductions in GP appointments. We saw a reduction in sort of prescribed medication. We saw that people had improvements to sort of self-managing chronic pain, and that was over 70% of people. One of the more unforeseen outcomes, I think, for us, the benefits to social support and peer support and creating sort of networks and communities. And we saw reduced feelings of isolation. And I think going back to one of the points that I was making earlier about the invisibility of chronic pain and not wanting to feel like a burden, that not physical tax of not wanting to feel like a burden means that some people are often isolated. A lot of the people that we spoke to in the beginning felt they was going through this alone. And so a lot of people were feeling very isolated. And we saw through this program, through just bringing people together in these safe psychological spaces that are naturally created by having diversity in the room, having, representation in the room, having people in the room with shared experiences where people are not having to, dictate what they're going through. They just get it. I think that is one thing that definitely helps. It creates a sense of understanding, sense of belonging. And so that was one of the biggest sort of outcomes of the project, is the reduced feelings of kind of isolation as well. We saw some more sort of formal, along with the sort of reduction in GP appointments and prescribed medications, we saw some more formal findings around people's experiences of pain. And we saw statistical significant improvements or reduction, should I say, in pain catastrophizing. So the way that people think about their pain, how they relate to their pain, which is huge. And it goes back to all the incredible work that the GPs did and the clinical psychologists, all of those people did on this project to support understanding of chronic pain. And yeah, across 2 years, we supported over 1,500 people in different ways. So that support looked very different. It's important to highlight that, and we talk about the levels of engagement in the report. But I think one of the big things for us was empowering people to engage with the project how they wanted to. So not forcing, again, not going back to forcing an approach on them. The program was there, and it was so varied because it did take into account the biopsychosocial approach. People engaged with the project very differently, but I think we are just all collectively very proud of what we achieved and what we delivered across 2 years. And I can't believe it's come to an end. But it's come to an end in this pilot form. I will say that we are working with some of our colleagues in Lambeth to scale and spread the approach, which is amazing. And again, it's just a testament to what people have seen. People are really drawn to the PEACS program. And I think we were really impactful because we had an incredible evaluation team that we was working with, the Tavistock Institute of Human Relations. They really supported us to be able to measure our impact and understand the data a bit more that was coming out of the project. And so we have these, we was able to develop a report that shows kind of the qualitative, quantitative aspects of the project. And yeah, it's now, it's something that is hopefully going to be scaled across Lambeth. And again, we've just had another person reach out to us, wanted to, collaborate on a grant. So yeah, fingers crossed. I think this I will always say this approach is wonderful. It's been one of the best sort of working experiences of my life, definitely. And yeah, I'm very, very honoured to have been here and to have shared this with you today.
And we're very honoured that you're able to come along and share it with us. And I really, look forward to sort of seeing how things go in the future and how things are scaled, because after reading the report, it's really clear the positive impact that this has had on, all of the people's lives that you've been able to work with so far.
Thank you.
Yeah. And also just changing the narrative in healthcare. Like, that sounds huge, but I think it's, you've made like huge waves in making sure that that's like the approach that is going forward. And it's so exciting, like Mariam said, it's so exciting to hear that there's like next steps.
Yes, one of our testimonies to the project, a lady called Angela. Angela, big shout out to Angela, who is our expert by experience, but she just won some funding from a local Lambeth initiative to continue on some of these peer support groups and work with the community provider. After having met people through the PEACS program. So there is longevity to this, and there is sort of pieces that will continue to be sustained now and until we do get that kind of scaled, formalized approach. But yeah, thank you for having me.
Thank you so much. I think that brings us to the end of today's recording.
Yeah, thank you so much for your time. Obviously, we've all said thank you loads of times, but it was just it was really, really interesting to hear about the report.